Well, thank you very much, Linda. I hope that you can all hear me. I have to say, I've been absolutely spellbound by Sonia, Linda, and Samuel's presentations there. So um, I think now it's something completely different. So I'd like to talk about endometriosis surgery and its impact on fertility outcome, when to operate. And I may also, if we have time, share a couple of cases as well at the end. So I'd like to make my disclosures, some of which, some of the affiliations you've already heard. And I would like to extend a great thanks to the Chinese University of Hong Kong and also to our sponsors, Abbott. I have been a consultant for Abbott for a couple of years now, although in fact dydrogesterone is not marketed in New Zealand for endometriosis. And I should point out that I treat women with endometriosis with medicine, ART, with Lipiodol, and also with surgery. And of course, surgery, when undertaken privately, does allow me to raise funding and do some very nice things with my family. So that also, of course, on a presentation about surgery needs to be declared as a potential conflict of interest. So what will we talk about this evening? I'd like to address what actually causes infertility in endometriosis. I'd like to talk about the role of laparoscopic surgery. Well, firstly, for diagnosing endometriosis, is it still needed? I'd like to talk about the evidence base in relation to the laparoscopic removal of endometriosis versus no intervention for fertility outcomes. Also, the laparoscopic surgical removal versus other interventions. And we'll be talking about a network meta-analysis. I'd like to talk about endometriomas. It's not always easy to know what it's best to do with them, particularly around concerns with ovarian reserve. And I'd like to briefly mention postoperative adjunct medical therapy and whether that's appropriate to promote fertility outcomes. We'll be addressing some key guideline recommendations. And then if we have time, we may well talk about some cases. So, of course, how does endometriosis cause infertility? Well, it affects the whole range of the genitourinary system, really. It affects the pituitary. It affects the ovary, ovarian reserve, and egg quality. It has an impact on the fallopian tube. It can also impact endometrial receptivity. And finally, of course, it can impact upon pregnancy as well. And one of the most important impacts, of course, is on the peritoneal environment. And we'll be talking a little bit more about this in a moment, about how surgery can potentially improve this. I'd like to turn to diagnosis of endometriosis. So really, we're moving away from a surgical mandated diagnosis, which has always been the gold standard. But even as far back as the consensus meeting that the World Endometriosis Society had in Montpellier in 2011, published in 2013, we were still talking about empirical medical treatment in the absence of a surgical diagnosis, although at that stage, it was really while we were waiting for a surgical diagnosis. The ESHRA guideline 2022 on endometriosis has really now called the requirement for a laparoscopic diagnosis of endometriosis now an outdated dogma, and is moving away from this. And certainly the World Endometriosis Society consensus on the diagnosis of endometriosis, which we hope will shortly be published in Fertility and Reproduction, acknowledges that now, this year, 2023, there's a strong case for treatment of endometriosis to be based on a clinical diagnosis of likely endometriosis supported by imaging findings when appropriate in lieu of the traditional laparoscopic diagnosis. So why shouldn't we do this? Well, of course, the laparoscopic diagnosis is established standard practice. And really, it must be said that the entire evidence base of treatment interventions in endometriosis, if we're thinking about randomized trials, it hinge on a laparoscopic diagnosis. Why should we move to this? Well, we now have sophisticated imaging with very high accuracy to allow a diagnosis that is more or less as accurate as with laparoscopy. And it should be remembered, of course, that if we think about the 5 million women around the world who are newly developing endometriosis on an annual basis, let's do the maths. There are not enough gynecological surgical hours in a week to even do a diagnostic laparoscopy, let alone a therapeutic surgical laparoscopy for all of those women. So we do need a new way of accurately diagnosing endometriosis. So now moving on with the ESHRA guideline and thinking about the treatment of endometriosis-related infertility, certainly in this guideline, there is really now no place for just a diagnostic laparoscopy. If we're doing a laparoscopy, we must proceed with surgical treatment. And from the fertility perspective, women who have the fertility wish, we also must have tubal patency testing. There's a mandate from the ESHRA guideline to use the endometriosis fertility index. I do find this very helpful to give women insight into their fertility prognosis once they've had laparoscopic surgery, and this is the endometriosis fertility index by Adamson and Pastor, which is good for the fertility prognosis. So let's now think about the fertility impact, or the fertility improving impact potentially, of laparoscopic surgery. So how does the removal of endometriosis actually work? Well, of course, if the tubo-ovarian anatomy is disordered, then we can restore tubo-ovarian anatomy through laparoscopic surgery, but also removing relatively modest amounts of endometriosis remote from the fallopian tubes and ovaries can have a positive impact on the intraperitoneal environment, hence enhancing egg quality and therefore embryo quality, and also the fertilization rate. There could be an endometrial impact, improving receptivity through endometriosis surgery, although we don't know this for sure. And it certainly would be speculative to suggest that endometriosis surgery can improve the pregnancy outcomes, which are known to be compromised in the context of endometriosis. So let's have a look now at the evidence base for laparoscopic surgery. And the first thing that I'd like to show you is the Cochrane Review. And this, I think this evidence base has stood the test of time. The Cochrane Review is still showing that laparoscopic removal of endometriosis significantly increases the chance of a pregnancy. Even a more pessimistic estimation of this, by including one of the slightly more negative studies, which we did in our paper, When to Do Surgery, When Not to Do Surgery for Endometriosis. And it is moot as to whether this paper should be included, but we're still seeing an improvement in fertility that's at the brink of statistical significance. Yeah, endometriomas, that's a difficult one. We have the Cochrane Review, which shows a significant improvement of excisional treatment for endometriosis as opposed to ablative treatment, so a cystectomy, which has a more significant improving effect on the chance of pregnancy. But we need to take great care with ovarian reserve and ovarian surgery. I think we all know about the AMH impact of ovarian surgery, and particularly removing endometriomas, especially with repeat endometrioma surgery, and especially if it's bilateral. Certainly, we should be considering drainage of endometriosis without the use of electrosurgery. We should always be discussing the option of fertility cryopreservation for women facing endometrioma surgery first, particularly if their ovarian reserve is already low. And we should be using surgical techniques to maintain ovarian reserve if we're removing endometriomas, including meticulous surgical technique, the use of vasopressin injected into the bed of the endometrioma, avoiding electrosurgery, and using suturing only for hemostasis without electrosurgery. So I think it's become quite challenging to know who to remove endometriomas for. But certainly there is the fertility benefit which prevails. So certainly the laparoscopic removal of endometriosis is supported by guidelines. The World Endometriosis Society consensus statements, our ACCEPT group in Australasia, the ESHRA guideline, the NICE guideline, and of course even our New Zealand endometriosis pathway of care. I'd like to now consider surgical removal of endometriosis in the context of how beneficial it is compared to other interventions. And the way that we have done this quite recently was in the formulation of a network meta-analysis, a systematic review of randomized trials and network meta-analyses that we published in 2019. I think many of you will be familiar now with the network meta-analysis methodology, which allows comparison of all of the different interventions that have been compared in randomized trials, compared with either placebo or with one another, allows us to construct rankograms, and finally, an evidence hierarchy table. And I think you can tell that I'm from down under, because we're presenting I suppose the most effective interventions at the bottom of this graph here, going to the least effective interventions at the top. Now, you'll note that IVF and IUI are missing because we reproductive medicine specialists have only ever randomized to different ways of doing IVF or different ways of doing intrauterine insemination, IUI, and we haven't exposed those interventions to RCT scrutiny against other treatments. But what is interesting at the most improved end of this graph is that we see that yes, surgery is statistically significantly beneficial, perhaps using an add-on to surgery such as pentoxifylline, but we're also seeing some benefit from medical treatments as well, GnRH analogs, as well as dydrogesterone potentially, although these were based on small numbers and therefore not statistically significant in the case of dydrogesterone. But I think that these are interesting comparative figures. What about hormone treatment alone for improving fertility in endometriosis? Well, we know that dydrogesterone, it's an old familiar friend really that we've used for repeat pregnancy loss treatment, treating luteal phase defect, and for luteal support in IVF. So we know that it's safe in pregnancy, and as we've heard from the video just now, that it doesn't suppress ovulation. We know from our network meta-analysis that there is some promise with GnRH analogs and dydrogesterone. Certainly a systematic review by Peng and colleagues published in 2021 showed a 68% pregnancy rate with dydrogesterone. That's comparable or contrasted, I suppose, with the results on the Orchidea study that we heard about just now, in which sexually active women who were taking dydrogesterone had a pregnancy rate of only 2.5%. But certainly, I think that the idea of that hormonal treatment should definitely not be used may need to be revisited by ESHRA in the next iteration. This, I think, was an interesting study. It's not randomized, but it's a controlled clinical trial where a Russian group, Orozov and colleagues, exposed some of the women who'd had surgery to postoperative adjunct treatment with the medical treatment dydrogesterone, and found a 76% pregnancy rate after 1 year in that group, compared to a 44% pregnancy rate in the group that had surgery only. I think it was interesting that they used dydrogesterone only in the luteal phase in this particular study. Hence, I think the high pregnancy rate, because of course using progestins in the follicular phase has a level of contraceptive activity. I'd like to move now just to briefly present a couple of cases. So my case number one is a 35-year-old patient who's never been pregnant. She had no endometriosis visualized on imaging, and her infertility was otherwise, with her partner, was otherwise unexplained following investigation, and she had a good ovarian reserve for her age based on her AMH. She tried IUI and IVF treatment and even a laparoscopic hysterosalpingogram, and was still not pregnant. So we recommended laparoscopic surgery. She had her stage 1 endometriosis removed. The tubes and ovaries were fine, and she became pregnant and had a baby. And I think it's important to point out that some women will not have a child, will not conceive until or unless they have their endometriosis surgically removed. Now, on the other hand, we have the same case, same details, let's call it case 1B, who didn't get pregnant. And indeed, many women will still not have a pregnancy in spite of surgical removal. Just a little reminder that we need to take care with ovarian reserve when we're removing endometriosis, and particularly ovarian endometriosis or endometriomas. But of course, removing the endometriosis could lead to improved outcomes from the other treatments. So it's worth working through those again, and perhaps this may be the case of the value of postoperative medical treatment with an agent such as dydrogesterone. I'd like to now move to case number 2. I've been very impressed with the urinary tract endometriosis presentations that we've seen so far, and I thought I'd better produce my own one. So this, in fact, was the biggest bladder nodule that I've encountered in a patient with endometriosis. So she was a 34-year-old paranorth, and initially she had pelvic pain that was preventing sexual activity with her partner, who subsequently became her husband, and they were very much desiring a pregnancy, but found themselves unable to conceive. Transvaginal ultrasound suggested a bladder nodule. The AMH was low for her age, 7.7 picomoles per liter, and all other investigations were normal. So, in terms of the surgical findings, this, of course, is the big bladder nodule with adhesions over the top of it. The nodule was almost 4 centimeters in maximum dimension. There was also other pelvic endometriosis. Perhaps the most of this was seen in association with the left ovary and beneath the left ovary, which this ovary was very adherent to the para-ovarian fossa. And there was also, interestingly, diaphragmatic endometriosis. So when we have deep endometriosis of, for example, the urinary tract or the bowel, often there is diaphragmatic endometriosis, and there were a number of nodules in this particular case on the underside of the diaphragm. So we had a revised ASRM score of 54, stage 4, of course. The Enzian score was FBFO of the diaphragm, and the surgical procedure comprised cystoscopic ureteric stenting hysteroscopy, and then laparoscopic excision and ablation of endometriosis, including a wide excision of the bladder nodule or partial cystectomy, and left ovarian adhesiolysis and ablation of the ovary with actually also with so here you see the bladder nodule being excised and repaired laparoscopically. There was excision also of the cul-de-sac, of 2 cul-de-sac nodules. And you can also see here that from the methylene blue dye studies, the fallopian tubes were patent. So the patient underwent surgery, and over the next 4 months, there was a gradual easing of urgency, frequency, and nocturia, which was back to normal by that stage. There was no pregnancy at 4 months, and after an initial vast improvement in the level of pain, There was some recurrence of both right upper quadrant pain and low-grade pelvic pain at 4 months. So GnRH analog treatment was used without back hormone therapy, and this was stopped after 6 months, at which time the patient was very concerned that she may not have a big time window to try to conceive. So she had 2 months attempting to conceive naturally, then had a Lepardol HSG with further attempts to conceive naturally, alternating these with a couple of IUI treatment cycles, and this was unsuccessful. So she then went on to have IVF, with a short course antagonist treatment regime using 300 units for stimulation. 9 eggs were retrieved, 6 fertilized. We had 4 blastocysts. The single embryo transfer was unsuccessful, and the first embryo thaw cycle with the warmed embryo transfer resulted in a pregnancy. So I think this illustrates the whole range of fertility treatments. It's always hard to know what impact urinary tract endometriosis per se has on fertility, and whether surgically removing urinary tract endometriosis has any fertility benefit, but it is often a marker for the kind of endometriosis that will impact fertility. So I think that's my final slide, and thank you for listening.
Thank you, Professor Neil Johnson, for your excellent talk. And there are some questions in the chat box. The first question is to Dr. Yi, and the question is whether the release of the ureteric obstruction will allow the recovery of the renal function despite there is gross hydronephrosis.
Well, thank you for the question. So in fact, it depends on the degree of obstruction. If it is a complete obstruction, and if it's beyond 2 to 3 months, there may not be any recovery. But most of the cases, especially in the cases of endometriosis, they have partial obstruction. So the prognosis is quite variable, and I would say that most of the time there is a certain degree of a reversal of renal function. However, if we look at the scan, the parenchyma is too thin, then there may not be too much room for further improvement.
Thank you, Dr. Yi. And the second question in the chat box, maybe Professor Johnson may answer some question about the peritoneal inclusion cyst and fertility. The question is, how common is peritoneal inclusion cyst be associated with endometriosis? And how much does it affect the function of the fimbria concerning the ovum pickup and the fertility chance?
Well, I think it's difficult to say how common peritoneal inclusion cysts are. Certainly, we know that that endometriosis can affect the function of the fimbriae. We know that ectopic pregnancy is much commoner among women who have endometriosis, and so we see through the peritoneal environment impact of even stage 1 and stage 2 endometriosis. We see a halving of fecundity, whether that's purely an impact on the peritoneal environment, or whether that is also an impact on the fallopian tube. It may well be. We don't know for sure.
And I have a question for Professor Johnson. You have some experience of using the dydrogesterone for the post-operative use after the endometriosis surgery in patients who are desiring fertility, right?
Yes. Well, a little bit of experience, although I have to say that the dydrogesterone is not approved for use for endometriosis in New Zealand, so it's an off-label use. So it's a little bit tougher to come by. But I think we recognise that that dydrogesterone, well, firstly, does not suppress ovulation. However, if it's used in a long course continually, of course, you then get progestin exposure in the follicular phase, which will have a contraceptive effect, even though ovulation is not suppressed. What I liked about the Orazov trial, the Russian trial, where it was used, was the fact that they used it only in the luteal phase. Now, of course, we don't really have a good, clear idea of how effective luteal phase only use is for treating pelvic pain. But certainly it did seem in that controlled clinical trial to have a beneficial effect on the chance of pregnancy. I mean, it was almost a doubling of the pregnancy rate in the group that had taken dydrogesterone. I mean, I think there's a place for a really well-designed randomized controlled trial here, looking not just at pain outcomes, but also fertility outcomes with the different ways of administering dydrogesterone. But, I mean, I think it's exciting because traditionally we've always thought that medical treatment should not be used for those desiring pregnancy. It just delays the chance of pregnancy. I think perhaps we're now realizing with these new dydrogesterone studies that may not be the case.
How about on the prevention of the recurrence of endometriosis? Have you had any experience of prescribing this medication to as a post-operative hormonal treatment to reduce the chance of endometriosis recurrence? Or what other hormonal use like Dianogest, OC pills, and what's your suggestion?
Sorry, was that question again for me?
Yes. For the post-hormonal treatment.
Absolutely. I think there's absolute clarity now that the use of post-operative hormonal treatment is important to reduce the chance of endometriosis recurrence. Whether that is, I think it could be GnRH analog treatment, although of course that's generally used only short term in courses of up to 6 months. It could be certainly the newer GnRH antagonist drugs that are coming through. So that's doubtless going to be an option. But of course, add-back hormone therapy is also a requirement there. The levonorgestrel releasing intrauterine system is a good option for long-term management. And of course the progestins such as Dianogest, the more traditional ones, norethisterone, redoxyprogesterone acetate, given orally, but as well now as dydrogesterone. And I think what we now realize is that even with gold standard surgery, endometriosis is a potentially chronic condition, and it potentially can recur. And I think those who choose to have surgery alone, even in the best surgical hands, will always have a higher recurrence rate than those who choose to have medical treatment, even long-term medical treatment. And it's very clear from randomized trials that is the case.
Thank you. And just I'm aware that you are using the NCN classification for endometriosis. And
yes.
Because currently in our units we use also the ASRM and for the severity of the endometriosis, stage 1 to 4. And the NCN classification, I'll be aware that worldwide it is becoming more common to use it. And so would you recommend every case we stage the disease preoperatively with NCN classification, intra-op stage, or the imaging MRI staging? We recommend to include the NCN classification. Because I'm aware that it tells a classification of the different compartments of the disease.
Yeah, look, I do recommend the use of the revised ASRM, the NZN classification, and for women for whom future fertility is important, the endometriosis fertility index. And certainly we produced a consensus statement from the World Endometriosis Society recommending the use of those classifications in everyone having surgery for endometriosis. I think, you know, if we're going to the trouble of performing surgery, we should be going to the trouble of documenting it fully with the best classification systems that we currently have. That is not to say that they're fantastic classification systems, because I think most of us agree that they're not, and that they have their shortcomings. Perhaps arguably with the exception of the EFI, those classification systems fall short really when it comes to being predictive of outcomes that are important to patients. And I think that what we need in endometriosis, and really it's only big data that is going to yield this. And I think the EFFECT program, the endometriosis phenome harmonization program, and the data collection that's going on through that, through WERF, the World Endometriosis Research Foundation, aided and abetted by WES, is a good way of generating the kind of data that we will ultimately be able to construct new classification systems to really better inform women about the extent and the impact of their disease, what that's likely to look like in the future for them, as well as predictive models of which treatments will benefit patients the most. And I think that it's those predictive and prognostic models, and those models that allow precision medicine and precision surgery, I suppose, and precision fertility treatment in endometriosis, which will be ultimately most useful. But we don't have those yet. But for the time being, Enzian, well, it's good to hear that you're using it. Certainly, that is my recommendation, to use that and the other classification systems.
Yeah, we're considering to adopt that because it's very informative into the detailed compartments, which we should all look into, whether before the operation, if the woman knows that, oh, the bowel is involved, the ureter is involved, the bladder is involved, to what extent should we operate? And agree that the surgery should not be too radical. It depends on the symptoms, but it should be included in the discussion before the operation with the patient. And at least
I like your thinking. Yeah, I agree.
We should also look out for it. So since there's no further question,
I think there's no more questions, and I think it's the time we have to show the group. And
thank you very much,
Professor Neil Johnson and Dr. Yi, for having such a wonderful time with us.
Thank you.
It's a pleasure. Thank you for having me.
Thank you so much.